This is not an FDA-approved standard option, what I'm showing you here, but it's taking the non-chemo element of the previously standard, the monoclonal antibody against EGFR cetuximab, and adding it to immunotherapy. There are 3 phase 2 studies that look at this. I'm showing you the one that's most widely cited. What we see on the waterfall plot is that it's a nice set of responses, both in HPV positive and HPV negative. And there is durability to this. And so this may become standard in the future. Right now, I would call it a reasonable off-label option, and there's a divide in oncologists whether to use it or to wait for more data. Now, up until this point, everything I've shown you has been the same for HPV positives and HPV negatives. We love all of our patients the same, but if there's a biologic difference to exploit, we want to exploit it. And so here, it's interesting, the immunobiology of HPV-driven cancer versus smoking-driven cancer are vastly different. In smoking-driven cancer, you have this inflamed phenotype with lots of mutations, lots of foreign stuff for the immune system to recognize. In contrast, in HPV-driven cancer, it's less angry that way, but we have these preserved viral neoantigens, this foreign stuff because of the virus that the immune system can recognize. And so biologically, they're as different as night and day. And yet, with all of our standard agents, including pembrolizumab, the efficacy is pretty much the same. And so for the patient doctor team in the exam room, it doesn't matter. When we start to get into experimental therapeutics, however, that difference in biology starts to radically matter. In smoking-driven cancer, the foreign stuff, the neoantigens, are going to be different from patient to patient. So if everyone listening to this podcast were to get cancer tomorrow, and you were to sequence them, apply advanced bioinformatics, and nerd out on it, that foreign stuff would be mostly different, not the same from patient to patient. In contrast, if you do the same thing in HPV, there are certain virally driven neoantigens or foreign stuff that every patient has. And that's exploitable for patient benefit with personalized immunotherapy. There are multiple efforts looking at this. There are multiple vaccine studies. I'm showing you the one that was just easier for me to get a picture for because I presented it last year, but the other one looks almost as good. And what was done here was a vaccine against these preserved viral neoantigens combined with pembrolizumab as the first therapy that patients received. Again, this is a waterfall plot, so every patient is a bar here. And anything north of the 0 line is growth. So this is the patient who did the worst on the trial. She had about a 45% growth in her cancer on the trial. These patients, their cancer stayed about the same. And these are the best responders, 2 patients whose cancer shrunk 100%, otherwise known as a complete response. And so this is very, very small numbers. This is a very new idea. But if you adjust this for the expectation by PD-L1, it's roughly a doubling of the response rate. So we're going to update this data at ASCO once it's ready. And if this follows through, it will be worthy of further study, perhaps even randomized study. The other vaccine study looked similarly good. And the other thing I want to mention before bidding you a good day is TCR. So the T cells are the cells being stimulated here by the vaccine. But what if you don't have a T cell active against the cancer already? So what TCR therapy does is they pherese out the patient's own T cells. And I won't go into detail what pheresis is, but they take them to the lab and they transduce them with a genetically engineered virus. And what the virus does in slightly plainer English is change what the T cell targets to target something on the cancer. And then you give back those T cells like they're a drug. And that data also looks really good and is a very promising future avenue for directed immunotherapy against HPV. So if I'm going to summarize for you, the standard of care right now is pretty much the same as HPV negative. If the PD-L1 is high, that's pembrolizumab alone. If it is low, meaning 1 to 19, it's pembro plus chemo. And if it's 0, it's either chemo plus cetuximab or chemo plus pembro. In terms of future options, directing against these viral antigens is what's most promising. We have early data from 2 vaccine studies and 1 TCR study, and I predict that those are going to be major winners that revolutionize the care of HPV head and neck cancer that is recurrent and metastatic. I thank you for your kind attention, and I hope this was useful.